Welcome to PAH.TV Clinical Insights. This discussion is about challenging case studies in pulmonary hypertension and is moderated by Dr. Richard Channick. Our panel discussants are Dr. Richard Krasuski, Dr. Vallerie McLaughlin, Dr. Ioana Preston, and Dr. Sean Studer.
Hello, this is Rich Channick. I'm from Mass General Hospital. And for this session, we're going to be talking about specific challenges with difficult patients. I think we all manage PAH patients quite frequently, but we're often faced with patients that don't sort of neatly fall into the classifications or those that present specific challenges. And so I think it's really a pleasure to have people with such experience who can really, I think, help us wade through some of these difficult questions. So what I thought we would do is kind of go around the group and see what kind of patients you found to be particularly challenging, and then we can discuss how we manage those patients. Maybe we'll start with Richard.
Yeah, Rich, I manage a lot of folks with complex congenital heart disease, and I have had quite a few patients sent to me for heart-lung transplant assessment. And when they come over, you know, one of the things we always assess is whether we can treat their pulmonary vascular disease, because sometimes we can take them out of their troubles and we can actually get them set back so that we can wait a number of years before we need to consider transplant again. Sometimes we have a tendency to wait too long, and that to me is one of the hardest things. We wait beyond the time we probably should be because we get them feeling better, and then it's a matter of, you know, do we want to take the plunge to do a heart-lung transplant?
Yeah, that's a really important point, and we face that all the time, and I'm a pulmonologist, but you know, go through sort of the basic principles of how we assess, you know, the size of the shunt, the degree of shunting for the audience that may not be as familiar with some of the terminology or the lingo with these congenital patients.
Sure. So we really want to assess pulmonary blood flow, and we want to assess systemic blood flow. And there is what we discuss as a QP to QS ratio. So that tells us the amount of blood that's going to the pulmonary vascular bed versus the amount that's going to the systemic bed. And what we believe is actually for simple shunt lesions, and the simple shunt lesions are things like ASDs, VSDs, PDAs, where there's a simple communication between the two sides, and it results in increased pulmonary blood flow. Now that starts out at an early stage, we have a QP-QS that's elevated. As you start developing pulmonary vascular disease, and it's still not clear, Rich, that we know why this occurs, because we see people with very large shunts that never develop PH, and then sometimes we see people with very small shunts in PH, and we have a hard time knowing are the two even linked. But the idea here is that basically we're looking at something that is, you know, then you actually start developing the disease, and actually the QPQS will oftentimes change over time. So if you develop pulmonary vascular disease, your pulmonary blood flow may diminish. And then at some point, it's a question of should we increase that blood flow somehow, you know, and how can we do that? Do we treat with medications where that ratio of blood flow may change a little bit, and are we making people better when we do that?
When can you actually close these defects?
So I think most people believe at early stages, before pulmonary vascular disease kicks in, is completely safe. We've actually just recently published some data suggesting that even early stages of pulmonary hypertension, you know, they have a worse prognosis. So I think this idea of closing and treating is probably something we ought to be thinking about more. And certainly if you see somebody who's got elevated pressures and you close a shunt, that should not be somebody that falls off the radar, because a lot of times they'll come back later with a lot of complications, and I worry about those folks.
Val, is that, I mean, you're the other cardiologist in the group, has that been your experience as well?
Yeah, and I think Richard was pointing out that we want to try to close early. I think the other thing is you don't want to close too late. I think one thing that sometimes I see now, especially with how easy it is to percutaneously occlude a secundum ASD, you know, someone presents with really PH, they see a secundum ASD, and they close it, and maybe they shouldn't have. The patient doesn't get better, and they just have more right heart failure.
So is it worth trying to treat medically a congenital defect that has a reverse QP-QS ratio to make it surgically
So I think we talk about that a lot more, Ioana, than we actually see it, because you know, I have yet to see somebody that is truly somebody that I would call Eisenmenger reverse their disease to the point that they can then be closed successfully and do well long term. I think that's a real rarity. I think the folks we often see are the ones who still have left to right shunt, and then we treat them a little bit and their left to right shunt goes up a little bit, but they still have increased pulmonary vascular resistance. And those are the ones, you know, that Val mentions that I think we struggle with and we worry, because if we close them, we potentially might make them worse. Now, I've actually gotten in a little bit, a few patients that we have actually created a smaller shunt. So we go in and we put in a fenestrated occluder device.
Right.
That way we reduce the amount of left to right shunt, but still leave right to left shunting potential. Because the other thing that's hard to assess, there's no way to assess when that patient's on the cath lab table what happens when they're under physical duress, right? The patient's lying comfortably on the table, you're controlling all their hemodynamics for the most part, but that patient may develop increased resistance when they exercise, and you know, those are the people that I worry about, the ones who may develop, you know, higher pressures with exertion, and you may end up closing something that is more significant than you think.
Right, and that's one of the reasons why even just a hall walk is so important in those patients, not even so much to look for distance, but to look at how much they desaturate. If they desaturate a lot, that means they need that shunt to help their right ventricle during exercise.
And Richard, I've always struggled with what other markers, if any, that you think that everything's not working and transplant is maybe something you need to consider. I find it, of all the subtypes, and they're all challenging, one of the most challenging to really say, this is the point that you're going to list them for that big procedure, a heart-lung transplant.
Yeah, it is very difficult, Sean. I struggle with this all the time, and you know, a lot of times, like I said, we'll try to step up their treatment, and they'll come back and then be feeling a little bit better, but maybe their right heart hemodynamics don't look so good. So it's hard to make that call.
Yeah, because these people, you know, often have a longer natural history, but as you say, at some point they fall off, and it's trying to figure out when that's going to happen. But those are certainly a challenge. Val, how about you? Any particular case?
Well, I think one of the major phenotypes that's coming into my clinic right now are those patients with, for lack of a better word, mixed disease, but with a lot of left heart disease. Everyone recognizes LV systolic dysfunction on an echo. Not everyone really gets LV diastolic dysfunction on an echo. So I have a lot of patients referred to me that have normal LV systolic function, but many risk factors for diastolic dysfunction, the metabolic syndrome, sometimes sleep apnea may be a component of group 3, but really abnormal right hearts, RV enlargement and dysfunction, and when you cath them, let's say you dry them out as much as possible and you cath them, you know, their wedge pressure may still be a little high or modestly high, but their mean pulmonary artery pressure is 45, 50, their cardiac output is low, kind of that what we are now referring to as mixed pre and post-capillary disease, really an unmet medical need, and there's really no specific therapy that's been demonstrated to be effective in those folks, but they're very symptomatic.
I mean, what do we do with these patients?
Yeah, it's a great question. You know, obviously the most important things are what I refer to when I'm teaching the fellows as bread and butter medicine. It's amazing how many people don't really pay good attention to bread and butter medicine. These folks have never gotten the lecture about sodium restriction, volume management. They, you know, don't take as much Lasix as or diuretics as they need. So all of that is really critical. Blood pressure control. I'd like these patients to have really optimal blood pressure control, exercise, weight loss, that sort of thing, compliance with CPAP. You know, you do all of that, and they still have a lot of pulmonary hypertension and a lot of symptoms. Again, it's really not clear what to do. There are some single center, but randomized control trials suggesting that maybe there's a benefit in terms of symptoms and even objective data such as exercise tolerance and hemodynamics using a PDE5 inhibitor in those folks, but those studies are small. I think some of the larger studies looking at PDE5 inhibitors, like the RELAX trial, really didn't study this particular phenotype, the mixed pre and post capillary disease with a lot of pulmonary hypertension. So that study was neutral, but I'm not sure it applies to this particularly challenging patient that I'm referring to.
Yeah, I think you've underscored, you know, the heterogeneity of the patient population makes studying them so difficult, and it's such a moving target with volume status and many other factors. How do you guys approach these?
Yeah, we do see even in our pulmonary clinic when they come with dyspnea, this population, and sometimes when they are dried out in the cath lab, it's difficult to assess, are there two coexisting diseases? left heart diastolic dysfunction and true pulmonary vascular disease group 1, or is it the mixed form? What we do in our cath lab, we challenge them when their wedge is 15 or around and it's not quite clear from the clinical picture. We end up doing exercise, but just because, you know, we favor exercise in the cath lab, but in other cath labs I know use a volume challenge to unmask a true high wedge pressure.
So how do you do exercise?
Yeah, it's difficult because there's no standard exercise in the cath lab. What we do is we have a recumbent bike and we cath through the neck. And we put them on the bike after we get baseline numbers, and we ramp it up based by symptoms. We don't do maximal exercise, submaximal exercise, but enough to increase their heart rate and the dyspnea score to try to
How do you measure cardiac output? Because that's something that I really struggle with.
Right.
Because, you know, the cardiac output increases significantly.
Yeah.
And, you know, to do a fit cardiac output, you have to measure oxygen consumption,
Right.
which, you know, putting somebody under a hood is not a big, you know,
It's
minor deal. It becomes this very
difficult.
elaborate
Yes.
scheme in the
Yeah.
cath lab. And then, you know, thermodilutions, if that cardiac output goes, let's say, above 10, you often get an error message when you're shooting your
Right,
thermodilutions.
right.
So that, to me, is probably the most struggling part of,
Right.
you know, how I assess them.
And the other challenge is the cardiac output drops immediately after you stop exercising.
Right.
So you have to get it at the maximal exercise or the peak of their exercise. We do thermodilution in the cath lab, even for exercise.
And the other challenge with that is one of the other measurements you're very interested in is what does their wedge pressure do?
Right.
And again, that's hard to measure when
Right.
they're tachycardic, when their respiratory rate goes up and, you know, they're moving a little bit even though
Right.
it's supine bicycle exercise, they're moving a little bit. So that's
They're
challenging.
Respiratory
challenging.
variation changes.
Respiratory
you know, people are breathing 30
variation.
times a minute and you see the thing going up.
I think there's a lot of like technical issues. I always teach, you know, group 2 is not a number, it's a phenotype.
Right.
And it's really the patient you know or suspect, the obese older patient with systemic hypertension, metabolic syndrome, that falls in that category. We're obviously very suspicious for that.
Sure, and I think it's also a challenge sometimes too. If you decide this is going to be someone you're going to dip your toe in the water and use the PDE5 with, how do you assess how they're doing? They're often a little more complicated in that way too.
Yeah.
They're not always the most active, the most conditioned, so some of the exercise measures aren't so great.
Yeah.
And I can think of patients in the past that we've treated that when they get a little volume overloaded, get into some trouble because there is that mix right there. And at what point do you pull the plug on an attempted treatment trial and say it's not helping, it's making it worse, especially if the patient had a period, which they often do, where they felt a bit better on it because they were volume managed. So they're a very challenging group.
And that's a critical point, Sean. I would never even try any of those therapies unless they were dried out as much as they possibly could be. And then in terms of measuring it, you know, obviously there's no data in this population, and mostly what I'm going for is quality of life, is improvement in their everyday thing.
I mean, I think the summary, you know, the most common form of PH and the most difficult to treat. So rough combination, but, you know, hopefully there's a lot more work coming along. Ioana, what about you? You have a difficult kind of patient?
Yes, quite a few, but actually the last patient that I found difficult to manage in my clinic is a patient who presented with severe hypoxemia and signs of right heart failure and cath-proven pulmonary arterial hypertension, who we put her on treatment, and lo and behold, she ended up in a local hospital with CHF. And it turns out, going back and looking carefully, that the patient had pulmonary venocclusive disease, PVOD, which is a rare subform of pulmonary group 1 pulmonary hypertension that can be unmasked if we use or when we use PAH-specific therapies, and this is one of the
So tell
cases.
our viewers who may not be familiar even with the terminology, what you mean by pulmonary veno-occlusive disease.
Pulmonary veno-occlusive disease is a special form of pulmonary hypertension where the disease is predominantly in the pulmonary venules. There is pulmonary arteriopathy also, but the majority of the disease rests in the pulmonary venules. And the problem is that if the venules are constricted and damaged and narrowed, it behaves, if you wish, like a CHF at the level of the pulmonary venues. And when you vasodilate almost normal pulmonary arteries or arterioles, there's a gradient with a shift in volume from the pulmonary capillary into the interstitium, and patients can develop pulmonary edema, if you would. And it doesn't happen all the time, but there is this, some patients develop worsening hypoxemia.
The viewers, you know, that, and sometimes hard to explain this, but the wedge pressure is normal in patients with PVOD.
Exactly. But they're specifically more hypoxic than the garden variety pulmonary arterial hypertension. They have a CAT scan with high resolution that may be very underwhelming but still abnormal in the interstitium. So the signs of PVOD may be really subtle, and you have to look carefully.
So I do think there's a little controversy there, though, about the wedge pressures, because I got to be honest, if you hunt enough in these patients, you'll find segments of the lung that are potentially more involved, and so you'll see some differential wedges. But I think you have to be very dedicated and hunt, you know,
and
around.
I think that the distinction, you know, you may be talking about larger vein stenoses, which is different than the PVOD.
Well, but PVOD is a patchy disease, and I agree with Rich. I mean, if I have the clue going into the cath that might be PVOD, maybe it's the hypoxemia for which I can't find another reason, you know, we'll try to get multiple wedge pressures, and you know, the variation can sometimes tip you off that it's really PVOD.
I think it bears mentioning that the Society for Heart and Lung Transplant just updated the overall transplant guidelines. That was one of the few things left in pulmonary hypertension as an immediate referral reason, because we're limited or unable to treat them medically in many cases. And if you are going to try and think you may have some success, still having them have that unless there's some well-known contraindication, and giving them that option is key.
So I would agree with that. I think immediate referral is something that you need to proceed with, but I've had the experience that you've had probably a half dozen times. You don't really think about it. There's nothing jumping out, and you don't realize it until they have pulmonary edema when you put them on therapy. But I've also had a handful of patients that do well and respond to, you know, very low dose, gentle PAH specific therapy. There was a patient that I cared for many years in Chicago. She may still be alive, that just lived on 10 nanograms of epoprostenol, and she did great.
Yeah, I mean, it's like a lot of things, you're trading off better RV function for maybe worsening oxygenation, but the net effect may be positive.
You know, I think one of the other things we think about controversy-wise is, you know, if you think the patient may have PVOD, how do you assess them hemodynamically in the lab? Do you do a vasodilator challenge or not? If you look in the literature, there's at least a couple case reports of people dying on the cath lab table. So from my standpoint, as long as you're using a vasodilator with a very short half-life, you're probably fine. But people that are using things like calcium blockers still in the cath lab, or they're using Flolan or whatever else, I think you have to be very careful, because you may induce a hypoxic spell like this, and the patient may not come back from it. So just to be aware of that.
Yeah, no, that's absolutely a very specialized form, and good thing we have
form with
doctors
challenging to treat.
No, a little. How about you, Sean?
So I think our equivalent on the pulmonary side to Val's case is the patient with parenchymal lung disease as well as pulmonary vascular disease. And just to pick a group 1 example, because it's one that doesn't necessarily make sense, group 3 is sort of easy to conceptualize, it's not the main of what we're treating, is the patients with connective tissue disease like systemic sclerosis. So these patients can have, and often do have, fibrosis and concomitant pulmonary hypertension, and when they worsen, sometimes when they're diagnosed, things are a little clearer. You can quantify the parenchymal lung disease, you know, spirometrically and so on. You can quantify the pulmonary vascular disease. But as they worsen, knowing where to go, and that many of them aren't going to necessarily be transplant candidates, means that it's really important that you try to stay on top of them and be aggressive and pick the right treatment. So
I mean, the question is always, when you have a patient with some fibrosis, when is the pulmonary hypertension explained by the fibrosis or the lung disease, and when is it, quote, out of proportion, which is a term maybe we're getting away from?
We seem to be, and I think that it's hard to give a perfect answer to the question, but one of the guidelines that Ginny Steen and others have put out there is to look at forced vital capacity percent divided by the diffusing capacity percent. And to give a simple example, if your FVC measure of your lung volumes is normal at 100% and your diffusion is 50%, that ratio is above the 1.6, it's 2, that looks all the world like a pulmonary vascular case. Whereas if things are really flipped and you have a 50%, say FVC compared to normal, and a 50% diffusing capacity, that would suggest that there's a lot more parenchymal disease there. So it's not a perfect marker, and it was really recommended more as a guideline to screen who needs to be up front. In my mind, every systemic sclerosis patient needs to be screened and be watched carefully for the development of this, but management is a challenge.
Well, I would also like to add that when you take a scleroderma patient and give them both fibrotic lung disease and pulmonary hypertension, no matter if it's group 1 or group 3 pulmonary hypertension, or you can't tell, those patients do very poorly. And so we tend to get very aggressive with therapy in those patients.
And then you have, the problem is by giving vasodilators or giving drugs that may lower PVR, you can worsen intrapulmonary shunting and VQ mismatch.
And it's a bit to what you alluded to a moment ago. You're trading off some oxygenation for functional capacity, hopefully preserving RV function.
So we always talk about that as a theoretic risk. How often do you really see that?
In that case, the systemic sclerosis, it's not a big issue. It's a much big issue, I think, in the true group 3s, and it's a reason to not just blindly add, the vasodilators for group 1 there, but it's not as big an issue. And I'll be asked about that, and they say I'm really concerned because radiographically I see a lot of interstitial disease, but depending on how that's progressed, I think not treating the pulmonary vascular part is much more likely to lead to someone's dysfunction and mortality than addressing that other piece, which is, you're right, if it's hypothetical, we don't see it really often.
Sean, do you use more inhalational therapy for those patients because of the fact you can deliver potentially the healthier part of the lung?
I do like that concept, and I'd say we have traditionally used more of that. But more important to me, Richard, and just which one you pick, is that you're aggressive, as Val said. You're using multiple therapies. So much sooner than the other classes, these are patients on combination, and often triple combination. But I think the inhaled therapies have a good role there.
Because it's interesting, I've had a few of the patients where, it was unclear. They had bad lungs, bad pulmonary hypertension. We were very resistant about using systemic therapy. And then we started them on systemic therapy because they clearly were having progression in their pulmonary hypertension. They did remarkably well. They surprised me, actually, how well they did without getting hypoxia.
They often do, because the pH is, a substantial contributor. And in my opinion, I'm not a pulmonologist, but it's a lot more treatable than the interstitial lung diseases in scleroderma patients. But I get where you're coming from. And something that I do sometimes in those patients is, rather than put the whole Hickman CVP in, we just put a PICC line in and try it for a few months just to see if there's going to be more desaturation, if we don't think it's going to work.
I think that's the critical point, is that there's too many unpredictabilities to really know, and trying the therapies, the key is careful monitoring.
And I think working with a center that's very comfortable with that is important too, to emphasize the referral center piece. There may be a practitioner who's very comfortable with oral therapies and maybe using them in combination, but these patients, due to the aggression and the need really to go on parenteral quite often, I think should get referred early.
Great. Well, I think we're probably out of time. Thank you for your attention, and thanks to our experts, even amongst the experts, there are challenges. Thank you very much.